Hello students, we're going to start the lecture with the principles of hemodynamic monitoring. This is for our section that we have for our last part of this last module. Now I told you last week I would be posting this, and what we have here is a representation of the technically three things that you need in order to have an adequate delivery of oxygen to tissue. One is heart rate, one is cardiac output, one is stroke volume. Heart rate times stroke volume gives us cardiac output. So when we measure blood pressure, for example, what we're seeing is a reflection of that cardiac output and that stroke volume, in essence, and how many liters per minute we're putting out. So we can get an idea that if someone's cardiac output is going up or down depending on their blood pressure. Now, so these things help regulate cardiac output. So these, the heart rate times stroke volume gives us cardiac output. That's only part of the picture. But when we get that information, we can get cardiac output. We have to collect that information using something called a Swan-Ganz catheter normally, but we can also estimate it, as I've already mentioned. We know what the heart rate normally is, but the normal amount of volume we pump out with each beat is between 60 and 130 milliliters per beat. So that gives us a cardiac output of somewhere between 4 and 8 liters per minute. Now, from the cardiac output, when we take cardiac output and divide it by body surface area, we get what we call something called cardiac index. Now, that's a much better and more specific value because what we find now is we can standardize a cardiac output for everyone in the class. Whereas if we just looked at cardiac output, it would vary too much. It wouldn't be able to compare apples to apples. So that means everybody in the classroom right now has somewhere between a 2.5 to a 4 liter per minute per meter squared cardiac index. But your cardiac output individually could be 4, 4.5, 5, 6. We don't really know. But we could definitely calculate the index and now get a better picture of how your heart's really functioning. Now, since cardiac output is a function of stroke volume and heart rate, and that cardiac output determines how much gets to the tissues, here's what happens when we actually have tachycardia. So you assess for a fast heart rate, and this is what you should be thinking. Fast heart rate, low blood pressure means we have a decreased cardiac output. So we don't actually have to measure the cardiac output to know that it's going down. But remember, cardiac output going down means we have less tissue oxygenation, so that means we have something called cardiac hypoxia. Another way the cardiac output will fall, remember we have the normal P wave, QRS complex, followed by T wave. Well, in this example, we have something called atrial fibrillation. And so we don't have a distinguishable P wave, which means that our cardiac output is going to fall, and in this case about as much as 20%. Now that could be a significant problem because people with atrial fibrillation oftentimes complain of lack of energy because that's resulting from the lack of oxygen delivery or sufficient delivery of oxygen to the tissues. Then of course we have extreme bradycardia. Someone's heart rate just simply slows down. But each of these either changed one of the variables, stroke volume and then the heart rate. So in cardiac output, the heart rate is going down. In atrial fibrillation, stroke volume is going down. Both of those cause the cardiac output to go down. Again, look at blood pressure. That's the easiest way to see this. So we have the regulation of cardiac output that we need to really focus on. One, what blood we get in the atria before the contraction is called preload. That's how much, in other words, it's like cocking a gun. We're going to preload it with a shell, and that shell is going to then fire. In this case, the preload is here, and then we have something called afterload. That's the force in which it has to work against. And then, of course, we also have something called contractility. All of these three variables affect stroke volume. So preload, how much volume in the ventricles or the atrium prior to the contraction that actually causes stretch. So we have to have stretch of a rubber band before the rubber band will snap back. If you don't stretch the rubber band won't snap. So what's happening here, the muscle is stretching as it fills up with blood. That's cocking the gun, if you will. And as the release of the gun, that's the contractility. When you fire the pistol or shotgun or whatever it is, when you pull the trigger, it ejects the blood, and that blood is ejected, but it works against resistance. So that resistance, if we use the gun analogy, is the resistance of the barrel. And of course, in our example, it would be the resistance of the vessels. So it's a major determinant of the cardiac output and the contractility of the heart. So we need to address that sometimes. We can't measure it directly, but we do have indirect measurements. So oftentimes we'll put a line in, and that line will actually give us the pressure leading into the atria. And we call that the CVP pressure. We can also get right atrial pressure from that line. And then, of course, we can measure something called left ventricular preload pressure or pulmonary artery wedge pressure. This is something we haven't really talked about, but these are pressures that exist in the heart, and we will talk about them most likely on Monday. Regulation of cardiac output, again, preload, volume, the distribution of the volume, the contractility, in this case atrial contractility, and of course ventricular contraction. So the contractility of the atria and the ventricles, the volume that is distributed, and the circulating volume along with that preload are all the factors that are affecting preload. You alter that, you alter preload, you alter the actual cardiac output, the delivery of oxygen to the tissues. So afterload, basically one word, resistance. Anything that works against the load. In the example I gave, you had a shotgun that had a barrel, and that barrel is resistance to the actual shot going through the barrel. An afterload in our case, any vessel or any valve is going to be afterload. So as the sum of the external forces that would oppose the ejection. So the barrel of the gun actually is opposing the ejection of the shot that's coming out of a shotgun shell or a handgun, but in fact it's also helping it eject. The aortic pulmonary valves, for example, are a major impediment to flow because they actually get smaller as it pushes through the system. So everything on the pulmonary artery side is the afterload to the right heart. Everything in the systemic system is the afterload to the left heart. So you get the idea. Think of what is downstream from that particular vessel or ventricle or atria, and that's the afterload. But we have other things. Remember Poiseuille's law. Flow is equal to change in pressure pi r 4 L, which is the length, and mu, which is the viscosity of the blood in this case. Yes, Poiseuille was actually describing blood flow through the heart, not through the lungs. So vascular resistance, the blood viscosity, the distendability of the vascular system, and the integrity of the valves themselves, so the aortic and pulmonic valves. Since this plays a major role in things in regards to how blood is delivered to the body, oftentimes we have to give medications that will improve the afterload. Or, in some cases, we have to give something that improves preload. Or we may have to also give something very specific to improve, say, contractility, the heart rate, or the blood pressure. So there are a lot of different drugs that we give based on this physiology. So the importance of evaluating afterload. Realize, consider that the higher the afterload, the greater the work. That's the bottom line. More work is created for the heart. That means we're increasing the work of the heart. We're expending oxygen. And therefore, the body will have to work harder. How does it work harder? Well, you pick up your respirations, your depth of breathing to make up the difference, or we give you oxygen. Contractility. Now, contractility is after the stretch has occurred, or if the stretch doesn't occur, we don't get any contractility. But if the stretch occurs, this is actually going to stretch the rubber band, if you will, or cock the hammer. And it helps us determine how far it contracts or how much it contracts. Take a rubber band and stretch it. The further you stretch it, the greater the force. Now, assuming you don't break the rubber band, now snap it. The greater the stretch, the more contractility. But if you overstretch it, you damage it. So that's something we want to avoid with the heart as well. All right, now, so the pulmonary artery wedge pressure is a way that we can measure the function of the heart. This is a pressure that we measure with a catheter. It's really all you need to know at the moment. But basically, we have to do sometimes things indirectly, and this is one thing that we can do is look at wedge pressure to give us an idea of whether we have too little or too much pressure to determine whether or not what we need to address. Wedge pressure specifically looks at the left heart. Again, the wedge pressure specifically looks at the left heart. Now, it's impacted a great deal by the systemic vascular resistance and the heart rate. So contractility, pressure, resistance, and the rate are all factors that can impact it. So contractility is also affected by the sympathetic nervous system. When it's activated, we contract more forcefully. But at the same time, heart beats faster. The heart beats faster, we contract more, we put out more cardiac output. When do you ever need that? When you're under stress. So your body naturally produces epinephrine to create this effect. Of course, we also have situations where we actually decrease contractility or the body starts to struggle. I'll give an example. Sympathetic nerve stimulation, the delivery of epinephrine to the heart, you'll have an increase in the contractility and the heart rate. If I give you a drug called a beta blocker, it is actually blocking the effects of epinephrine, therefore will reduce contractility and reduce heart rate. They oftentimes give beta blockers to patients who have high blood pressure. And then there are other things, of course, like hypoxia and hypercapnia and acidosis that also depress our system. So we have to be careful that we don't allow someone to become hypoxic or hypercapnic or acidotic, because this can affect overall contractility of the heart. So why do we give oxygen to patients with heart problems? Because it'll affect the cardiac output if we don't. So cardiac blood pressure is equal to cardiac output times systemic vascular resistance, or what we call SVR. So when we measure blood pressure, once again, it reflects cardiac output, but it also reflects resistance. So think of it this way. The higher the blood pressure, the greater the resistance. The lower the blood pressure, the less resistance. So if we have less resistance, then that means we may not be pumping the blood through the system as well. So when blood pressure goes down, cardiac output is going to fall. When systemic vascular resistance goes down too much, our cardiac output goes down. Our blood pressure goes down, and then our cardiac output goes down. So the bottom line is these things are blood pressure is a direct reflection of these two aspects. Now remember, cardiac output is a function of the contractility of the heart, the preload, and the afterload. So we have to remember that there's a lot of factors when we measure blood pressure as to what we're seeing. All right, now the regulation of the cardiac output, we have the heart rate, we already know, is between 60 and 100 beats per minute. Now, if we are actually going to maintain that, if somebody's heart beats really fast, then we can give something called, like we mentioned before, a beta blocker to slow it back down. If we have a problem with cardiac output because of preload problems, we want to increase preload, so we give volume. If there's an issue with afterload, we want to decrease afterload, so we'll give something called a vasodilator or a calcium channel blocker or a diuretic to lower the load of the heart. In other words, we don't want a heart working too hard because it's going to burn up more oxygen. If there's an issue with contractility because there's lack of contractility, then we want to give something that's going to cause the heart to contract more. So we're going to give different drugs depending on one of these, if it's the heart rate problem, is it a preload problem, is it an afterload problem, or is it a contractility problem? You have to remember that when the cardiac drug is given, it's given for one of these four reasons, or all the above. So these are all the interchangeable ideas that we have to consider: preload, contractility, afterload, stroke volume, the overall cardiac output, and the heart rate. The bottom part right here is what we're really dealing with when it comes down to treatment. Do we want to speed up the heart, slow up the heart? Do we want to increase or decrease preload? Do we want to increase or decrease contractility? Do we want to increase or decrease afterload? In many cases, we have to address each one of these individually. We can't ever think that we can address all of them at one time, but sometimes we have to do that. So we have to give drugs that would then actually affect all 4 of these aspects. And you'll be learning about those drugs later, but I just wanted to point out that the drugs are based on these 4 elements. All right, this concludes this part. We'll come back to the next video and we'll be discussing a little bit about the pressures inside the heart.